Set yourself straight, learn how to live free. Addiction is a dead end road of pain and misery. I didn't know which way to go.
Hey folks, I'm Jerry, the sober guy, and welcome to Recovery Today, the only show in the Tri-Cities area and beyond that dares to take a look at alcoholism, addiction, and recovery from it. This show is not aligned with any recovery organization, institution, or organization. The views here are that of my guests and my lovely co-host, Deanna.
Hi, everybody.
Want to thank Heritage TV for allowing us to have the show on. Well needed, long overdue. Now, with that said, I'm going to turn it over to Deanna, and she's going to introduce our guest today.
Okay.
Aren't you?
So hi, everybody. Hope you're having a great week. We have Dr. Shaw with us today, and we're just going to ad-lib addiction in general. And so, Vance, if you want to talk a little bit about yourself. And
Okay. I've been practicing medicine, I guess, for the better part of 2.5 to 3 decades at this point. I'm board certified in family medicine and practiced emergency medicine for about 20 years. Just recently quit doing that in favor of full-time addiction medicine. I was board certified in addiction medicine, I guess, about 1.5 years ago, and since then I've been doing that full-time. What I kind of wanted to talk about today is the change in perception of addiction in the medical community. Now, as I said, I'm family practice trained and boarded. And a lot of things occur in family practice over the past decade, or a couple decades actually, as far as what's considered to be a part of family medicine. Now, when I was first finishing up my family medicine residency, HIV came on the scene. And at that time, HIV was considered to be a disease that was treated by specialists, the infectious disease people. But as it grew in severity and the numbers of people infected with HIV, the American Academy of Family Practice came out and said, no, this is now a primary care disease. This is a disease that we take care of in the family practice's office. And since then, there have been a couple other instances similar to that. One is chronic pain. Chronic pain initially was managed by pain management specialists, who were usually anesthesiologists. But it's become such a large problem in the United States that we've shifted the focus from the specialist to more of a generalist. And again, family practice came out with a statement a couple of years ago stating that chronic pain is now a disease that is cared for by primary care physicians. Okay, so there's been that shift both in HIV and in chronic pain. Now, fairly recently, in the year 2000, the federal government passed a law called the Data 2000 Law, which stands for the Drug Addiction Treatment Act of 2000. What that law essentially states is that addiction is such a major problem in the United States, and you've got to understand there are as many addicts as there are people with type 1 diabetes. We get a lot of training in the practice of medicine in type 1 diabetes, but very little training, of course, with regards to addiction, but that's another subject that I'll talk about in a few minutes. But because this is such a large problem, the federal government has stated that we need to look at this from the standpoint of being a primary care disease. And that's what that law basically did, is it said it empowered primary care providers to treat the disease of addiction in their office. Okay, so this broadened it out now from a specialist disease to that of a primary care provider. Now, there is still a specialty component to it, just like primary care doctor can take care of people with heart disease or diabetes. You can also go to a specialist like a cardiologist or an endocrinologist if you need additional treatment. And certainly there is a place for specialized treatment in the treatment of addiction. But by and large now, for the average person who is dealing with addiction issues, a lot of times that can be dealt with in the family practitioner's office. And this disease is really uniquely suited for primary care because it affects so many aspects of a person's life. It affects not only the person themselves, but of course there can be diseases that are associated with it, like hepatitis C or infections from IV drug use. There can be health issues just from the standpoint of not taking good care of yourself. Plus there can be issues, of course, with regards to the family, emotional trauma issues. So there's a lot of psychosocial issues that are involved that family practitioners are very good and well-versed at dealing with. So that's a big change, at least since the year 2000, in the focus of how we treat addiction, whether it's a specialist disease or more of a primary care disease. Now, I look at it from both standpoints. I am a primary care provider. As I said, I am board certified in family practice, but also recently became board certified in addiction medicine so that I could more specialize and study more of the intricacies of the disease. And I've been doing that basically full-time for the last couple of years, working with different practices in town. Now, I've been practicing addiction medicine for about 7 years while I was still working in the emergency department, and just gone full-time with addiction medicine over the last 2 years. Now, I know that there's been a lot of discussion about Suboxone or buprenorphine on this program in the past. And that's really, I'll talk a little bit about that because I think it's a very important subject. One misconception that people tend to have about addiction is they don't tend to look at it as a real disease. Now, both the American Academy of Family Practice as well as the American Medical Association clearly state that addiction is a disease, and we can actually point to specific genetic mutations that cause a person to be born basically an addict. So we have to look at it from the standpoint of it being a disease. Now, there is no other disease in the practice of medicine that I've been able to find anybody that can think of that is not okay to treat with medication. If you're a diabetic, it's okay to take medication for that. If you're schizophrenic, it's okay to take medication for that. If you're bipolar or depressed, there's medications to take for that. But for some reason, people think that addiction is different, that you're not supposed to take a medication to treat addiction. Well, that's absurd. Now, part of the problem is that in the past,
That's us.
part of the problem is in the past we haven't had medications. So all of the treatment for addiction has been considered to be abstinence-based, not because it's not a good mode to work with using medication to treat addiction, but just because we didn't have anything. So it's a real paradigm shift for people in the treatment of addiction because we just haven't had that medication until now. Now, what you've got to understand about buprenorphine is it is the first drug to treat addiction. It's not substituting one drug for another. It is actually a medication that treats addiction, and that's something that people have a little trouble wrapping their heads around. For example, if a person has schizophrenia and they take schizophrenia medicine like Haldol, it will clear up their thinking and they'll become normal. If I take Haldol, it would make me very goofy. Okay, so you have to use the medication to treat the disorder. And again, with diabetes, if you give a diabetic diabetes medicine, their blood sugar becomes normal. If I was to take diabetes medicine, I'd slip into a coma. So it would not be good for me to take diabetes medicine if I'm not diabetic. Same thing with high blood pressure medication. If I took high blood pressure medication, my blood pressure would drop so low, I would pass out. Now, buprenorphine, when you give buprenorphine to a person who is an opioid addict, it makes their brain function normally. Okay, now if I was to take buprenorphine, I would get a little buzz from it, but that's because I'm not an addict. Okay, now people say, well, if people can get high from taking buprenorphine, then that's a problem. Well, high school kids will take cough medicine, dextromethorphan, Robitussin DM. If you drink enough of that, you get high. The cold medicine, Coricidin, they call those Skittles. If you take enough of those, you can get high. When I was in high school, they were taking not sunflower seeds, but morning glory seeds to get high.
Yeah.
Nutmeg. Of course, there's always alcohol. So there's lots of things that people can take to get high out there. But the thing that you've got to realize is that buprenorphine is safer than all of these things. Okay? Buprenorphine is literally safer than Tylenol. More people died from Tylenol last year than died from buprenorphine. It is impossible to overdose on it. So if someone's going to take something to get high, it's actually a much lower risk medication than even a lot of stuff.
So
they
the
get over
argument
counter.
will be, but there are people who do die from it, so why?
Okay, well, that's not really true. It's an association. People who die who have buprenorphine in their system actually die from all of the other drugs they took along with it.
Right.
That's like, say for instance, you took a lethal dose of Tylenol and then drank a bottle of Drano.
Right.
On autopsy, you would have a lethal dose of Tylenol in your system, but it was the Drano that killed you.
That's right. That's right.
So the only cases where you can see that people died from buprenorphine were what we call polysubstance overdoses, where they took a whole handful of a lot of other things, and it's the other things that killed them. Now, certainly you can have what's called an idiopathic reaction, like an allergic reaction. But again, more people died last year from reactions to penicillin than died from buprenorphine.
What about the other drugs? There are other drugs out there to treat, like alcoholism and, you know, cravings for cocaine and any of that. And we aren't hearing a whole lot about those. We're hearing about the Suboxone clinics that are opening up all over.
There's a couple of reasons for that. One is, like I said, addiction has a very strong genetic component. In this part of the country, there are a lot of people who carry that gene for opioid addiction. Right. So we have, as everybody knows, in this part of the country, about the highest use of opioids of any place in the country.
That's right.
Okay? And a lot of that has to do with our genetic predisposition in this part of the country. The other thing that we're hearing, or the reason we're hearing a lot more about Suboxone, is because it is the only drug really now to treat addiction. Right. We don't have a drug to treat meth addiction. We don't have a drug to treat benzodiazepine like Xanax addiction. We don't have any medication to treat that. We've got a few medications that are a little bit helpful for treating alcoholism, but certainly not with the success that buprenorphine has. Before buprenorphine, we had, as I said, the abstinence-based approach. In other words, don't take anything. That has less than a 20% success rate. Since buprenorphine came out, it has, depending on which study you look at, between a 50 and 80% success rate. So it has 3 times the success rate of anything that we've had before. Now, there's no other field of medicine where if you had a drug that came out that was 3 times as effective as what you were doing before, that people wouldn't jump on the bandwagon for that. But unfortunately, because of the prejudice that people have towards addiction, and that's a big, big part of the problem.
Right. Yeah. And really and truly, a lot of those prejudices come from their own childhood of living with an addict or living with an alcoholic, or, you know, things like that that go with that, as well as the mix of religious teachings and different things too. So
well, and you know, if you live in a family with a diabetic, the diabetic's not going to steal your stuff.
Right. Exactly right.
Whereas an addict who's using is likely to steal from their family and friends, and so that's part of the disease, you know, and people don't understand that's part of the disease. It's like schizophrenics. You know, when they're in the midst of their disease, they make little hats out of aluminum foil because the VCR is talking to them. So they act quite odd. And their behaviors are part of their disease. But what people don't understand is some of the behaviors associated with the disease of addiction are lying. That's part of the disease. Stealing from family and friends is part of the disease. Now, the other thing is people...
But the other part of the disease is those are also part of a bipolar disease.
Well,
when they're really manic at points, there are some bipolars who also steal from families, shoplift in the middle of a mania.
That's true.
It's not just addicts that have that as a component of the disease.
Well, schizophrenics do that frequently
absolutely.
also.
But we like to believe that only addicts do it, right? Only addicts do this. Yeah.
You know, and the other thing is that people have this misconception that addicts are going to break into your house and steal your stuff.
Right.
There's absolutely no substantiation for that. Now, you've got to understand there's 2 entirely different diseases here that we're talking about when we're talking about criminal behavior. Okay? Addicts are normal people who are driven to extraordinary conditions, okay? And they will steal. If you leave a $20 bill out on the table, they'll steal it, okay? But they will not break into your house. That is contrary to their nature. On the other hand, you have antisocial personality disorder.
Deanna, Jerry.
Now, antisocials, whether or not they're using drugs, will break into your house and steal your stuff and beat you up and things like that. That's part of antisocial personality disorder. Now, part of antisocial is frequently they do get involved in substance abuse, but that's not what's causing them to be antisocial. So
okay, so now I need to stop because here comes Jerry.
So what you're telling me is the addict who breaks into my house was predisposed to be a housebreaker way before?
Yeah, he broke into your house long before he got into drugs.
All right, that's all I want to know. See, I never knew that.
And that's
I
part
never
of
knew
the,
that.
you know, that
Because
kind
I
of,
hear that a lot of my work today.
Yeah.
You know, I had to go steal. I had to do this. So he's already had that in him.
and
To be a thief.
you know, people who rebel against society, part of that's going to be substance abuse, drinking and drugging and that
Yeah.
type of stuff.
Yeah.
So that's kind of part of that whole scenario. But when you look at the average addict who's not antisocial and their behaviors, they tend to do things like steal from their family, they'll tend to write bad checks, they'll tend to max out credit cards or kite checks. They'll do basically crimes like that are not confrontational and violent crimes. These are not violent criminals.
Yeah.
Now, part of that goes to our legal system in the United States. The United States has the highest incarceration rate of any country in the world. 40% of those people are nonviolent drug offenders, which actually exacerbates the problem, because one of the things that tends to make addiction worse is emotional trauma.
That's
and I can think of nothing more emotionally traumatic than winding up in jail.
Right.
Yeah. I hate to say it, but it sucks.
Fortunately, that's one experience I have not had in my life.
Yeah.
But frequently with my patients, if they have some reason that they have to go back to jail, if they get into recovery, they're doing well, but some old charge comes up and they wind up back in jail, it sets them back months in their recovery, because when they come out, they're just totally trashed psychologically. So, that's a whole other subject we could talk for hours and hours about.
One more thing. One more thing. Now, you're talking about that well-mannered addict that wouldn't do that. Will addiction push him into kind of going out of his range a little and perform or commit an act that he normally wouldn't do?
Some of the worst examples of that are women who turn to prostitution for drugs.
Okay.
Now, they will not hurt other people, but they will hurt themselves.
Yeah. All right.
And so it's not, if it's not part of a person's nature to be violent, they will not become violent towards somebody else in the throes of their addiction, especially opioid addiction. Now, certainly there are some addictions or some substance abuse disorders, like for instance people who are on PCP or people who are on methamphetamines, where they can become aggressive. But that's more of the exception.
Or me with alcohol.
Or you see it a lot more with the legal drugs.
Happy-go-lucky drunk, but at the end of the night.
And Jerry has told us this in previous programs, is your childhood was about violence.
Yeah.
So you already had the violent pieces.
All right, now I'm understanding that.
Yeah, you already had the
Maybe
violent pieces, even though
But I was
when
never
you started.
driven.
Yeah.
I was never driven to breaking in. Stealing's not my bag.
Right.
Yeah, so you're a perfect example of that. If it's not part of your repertoire before you become a substance abuser.
I'd go on the arm to my friend for money,
Right.
so I could get my dope rather than break into Joe's house.
That's right.
It's not my makeup.
Yeah.
I can't do
Yeah.
that. No, I understand that now.
So we've actually
Kind of
got
making sense of this whole thing.
scientific evidence
So. Cool. Continue on, Doc.
All right, so that's kind of a basic thumbnail of where the practice of addiction medicine is going, that it's really becoming a primary care disease at this point. It is truly a very substantial percentage of the population that does have addiction problems. I think the estimate is 23 million people, which puts it on par with type 1 diabetes. So we really need to start viewing this differently. Really addiction is the only disease, true disease, where people have the idea that it's a moral failing.
Yeah.
And we see that over and over and over again. And it's no more of a moral failing than a schizophrenic who hears voices or, that type of thing. So, our societal attitudes need to change with regards to that, because it's counterproductive.
Right. We've talked before on the show about, we don't look at smoking as a moral failure.
Mm-hmm.
You go to church, and right after church, half the congregation goes out and smokes, but nobody's standing out there telling them how awful they are, or those kind of things. Or
David, you notice you always picks on the smoker.
I used to be one, so I can do this. Okay, let's talk about your Dr. Pepper, Jerry. But I think it runs the same, because a lot of times when I have my addicts and I have them talk to their families, because their families don't want to be involved. You go get fixed and then you come back.
Yeah.
And trying to get families involved in all of that. And they go, I don't know how to explain it, but yet they can sit and say their whole family sits around the table and smokes and drinks.
Yeah.
But if they can get over their drugs, then it's going to be great, because it's the drugs that are the issue, not the alcohol or the cigarettes.
Well, a lot
and
of-
all of those kind of things.
A lot of patients grow up in families that are substance abusers.
Oh, absolutely.
And a lot of it has to do with attitudes too. I was working in the ER one day, and I had a mother bring her 16-year-old daughter to the ER because the daughter broke up with her boyfriend. And the message that mom was giving to the daughter is, you need a pill
Right, to
to fix this. So if you grow up in a family that's emotionally distant or uses drugs in order to cope with life, then you learn that message at a very early age. And basically the statement is in addiction medicine that the day you start using drugs is the day that you quit growing emotionally.
Right.
So I have a lot of patients who they grow up in families where the parents give them a joint when they're 12, or give them a beer.
Or shoot them up.
Yeah,
Yeah.
in really bad situations. So what you have in a situation like that is a person who quits growing emotionally at the age of 12.
Right.
And before they can really get better, they have to develop coping skills and grow up emotionally. So one of the terms that we tend to use in addiction medicine is it's not rehabilitation as much as
That's
it's
right.
habilitation. Because a lot of these people, when they come to see us initially, they try to get a job, they go out and get a job, and the first time they have conflict with their boss, they quit. Because they think, well, that's what you're supposed to do. Nobody has ever taught them that no, that's part of having a job, is you're not going to get along with your boss, and you just plow through it, you do your job.
Right.
Thank you.
So a lot
Do we need
of
to
it-
hear that today?
I did need it. I'm sorry. I needed to hear that today.
So a lot of the process of getting over addiction has to do with learning how to live life,
Right.
like an emotional adult.
Right.
And that's something that a lot of people don't understand about addiction also, is that a lot of these people are disadvantaged because they didn't grow up like middle-class Americans like the rest of us did. So they're a little bit disadvantaged on that playing field. But, one other thing I'd like to say about addiction, I mentioned the fact that it has a strong genetic component. But the other component is the emotional trauma component. For instance, you get soldiers who come back from a combat situation with post-traumatic stress disorder. They have an extremely high rate of substance abuse. The other group of people that has a very high substance abuse rate are women who've been sexually abused, either in childhood or as adults. And I was listening to NPR the other day and was astonished to hear that the statistics currently are half of all women in the United States have been sexually abused.
Wow.
Well, that makes for a huge number of women who are addicts simply because they've been sexually abused. And what I tell people, when people say, well, this is a choice, I say, a woman doesn't choose to be sexually abused or to be raped any more than they choose to be an addict. One follows the other. So to judge women who've been through that type of thing and are trying to cope and lead their lives by using drugs as a way of coping, you can't really fault them if that's the only coping skill they've got to try to make it through life.
Right.
So until we start looking at it from the standpoint that we have to treat the underlying problem, which is the emotional trauma, these people just aren't going to get better.
And that's true. I mean, when I was at Magnolia, we were looking at like 92 to 95% of all the women that came through trying to get well
And
as having been sexually abused. About 50% of the guys would say it for the very first time.
Yeah.
In their 40s, 50s, and 60s, that had happened to them. So, we're, actually in treatment trying to get well,
Yeah.
about 50% of men in 92 to 95, depending on, who's in there. But that's a pretty average across 9 years.
And that's been my experience too.
Yeah, of folks that really do want to get well,
Right.
who want to be different, but we're not.
And that's why I love Deanna so
Yes.
much, because she's doing the real work as far as dealing with those issues regarding abuse.
Right.
Because these women will not get better until that problem is addressed. But like I said, the other half is the genetic component. Now, a lot of times people who have a very strong genetic component may never come off of their medication.
Right.
And that's another misconception. There are a lot of people that think you go into a treatment program, Suboxone treatment program, and after 10 weeks, by God, we're going to force taper you off this medication and you're going to live happily ever after. Well, if they have a strong genetic component, that's not going to happen. And again, the medical community is unanimous in stating that we treat addiction like any other chronic relapsing illness. That you don't taper a diabetic off their diabetes medicine. You don't taper a blood pressure medicine off of someone who has high blood pressure. You don't taper schizophrenia medicine off of somebody who's schizophrenic. We have to start looking at it like a certain percentage of people will have to remain on their medication. Now, the best way to tell is like with diabetics. If they lose weight, start eating the right food, maybe we can take them off their medication. So we get people in counseling,
Right.
get them the resources that they need, and then we try taper.
And the interesting thing is that, and Jerry is starting to see this as well, is that when you have folks that do not have the genetic predisposition and you help them with the life problems that keep them mirrored in there,
Sure.
they are the ones who say, I think I'm ready to slow down.
That is exactly
I think
right.
I'm ready to give it up. And if we'll just listen to the addict themselves, and my mantra for several years is, you know from knowing you before, has always been, not everybody who looks like an addict is an addict. That there are varying degrees of addiction, just like there are varying degrees of diabetes.
Exactly.
And so, yes, I may be in full-blown addiction today, but if I get help with all of this stuff, and that's taken care of, and I go off my medicine, I may never have really been an addict as far as the disposition, and I can learn to behaviorally take care of myself. I no longer have to say, I'm an addict. I no longer have to do all of those addict things to stay sober, because I've learned how to manage my life. And I didn't have that predisposition for addiction to start with.
Yeah, that's exactly
and I
right.
think that part of our problem as a culture is we want a cookie cutter.
Right.
You're an addict, so you go over here and do this,
One
and
size
you do
fits all.
this, and yeah. So,
And it doesn't work.
right. And we have to, Jerry, you're going to interrupt us because it's almost time
No,
to
I don't
quit.
want. We'll go for another round, man.
We've got a minute. You want to wrap us up?
Doc, that was great, man.
Well, thank you.
I'm looking at it different because I'm the dinosaur, and I guess I did categorize addicts, and
Well,
now I got to take a better look at that.
When there is a paradigm shift, it takes a while for everybody's attitudes and opinions to change.
Yeah, yeah. Well, folks, that wraps up another quick half hour of recovery today. I want to thank my guest, Dr. Shaw.
Thank you.
And my lovely co-host.
Love you.
Yeah. I'll end it like I always end it. Of course, I might be afraid to say this right now. I don't know after what
Go for it, Jerry.
But I'm going to say it anyway. If you're out there, you're having a problem with alcoholism and drug addiction, and you're not doing anything about it, you're just spreading the disease.
But
I don't know if I
it's
should've
still